going to touch on that.
I know it's pretty nasty, so.
Oh, yeah. All right. So we're going to talk about respiratory this morning. And we're going to talk about some of the causes of respiratory problems. Some of the main problems that you'll see patients having, or things that cause respiratory problems, are dyspnea and hypoxia. Specifically, pulmonary edema, hay fever, pleural effusions, okay? And what a pleural effusion is fluid building up between the layers of the chest wall and the lung tissue itself, obstruction of the airway, hyperventilation, okay? Specifically hyperventilation syndrome, industrial or environmental exposures. And you'll see those with people being outside or exposure to certain chemicals or dust, and then of course drug exposure. And the reason that they'll have it with drug exposure is basically central nervous system depression. Okay. Some of the others may have a gas exchange obstruction. In other words, gas is not being moved from one side from the lungs into the bloodstream like it should. That the alveoli either have atelectasis or are damaged because of chemicals. Also, that they may have obstructed airway passages. That could be a big reason, and that could be because of mucus. That could be because of several reasons. Okay, this happens a lot in your bronchiolitis, bronchitis, pneumonias, obstructed blood flow to the lungs. In other words, again, a pulmonary embolism. Perfect reason for that. And then excess fluid in the pleural space. Well, that's the space in between the chest wall, the visceral and parietal pleura, as we call them. But if fluid builds up in there and too much builds up in there, it's not going to allow the lung to fully expand. And again, what that's going to cause is severe pain. It's going to cause very shallow breathing. Okay. This is just some of the signs and symptoms. You'll see that. It's a table inside your book. It's a really good tool, actually, to show you what some of the signs and symptoms of respiratory distress are and inadequate breathing. The biggest one is going to be skin. Remember, skin, color, temp, and condition are going to be the things that are going to clue us to what's really going on with this patient. It gives us a very telltale sign of what is and what isn't. Okay. Look at the nail beds. Look at the lips. Those are some of the first things that you're going to see a change in. Okay. So when we have an upper respiratory or lower respiratory infection, one of the things you're going to see with these patients is you're going to see cough, and you're going to see heavy cough. Some of these cause obstruction, like I said, excessive mucus production. Remember, oxygen exchange can only take place, or gas exchange can only take place through surfactant. Any other fluid that's inside those lungs, gas exchange is not going to take place. Okay, it's just not going to happen. So if you have mucus built up, you have secretions built up, you've got dust and dirt built up from say you're inside sawing on, you're working in your workshop sawing on wood, whatever, doing a renovation of a home or whatever. It doesn't matter if that dust and dirt builds up inside those lungs. Guess what's not taking place? Gas exchange. So you'll become severely dyspneic. You'll have extreme difficulty breathing. Okay. If you have swelling of the soft tissue in the upper airway, well, and we're going to talk about some diseases that specifically deal with that. Specifically, things that cause stridor, like croup. Okay, impaired exchange of gases in the alveoli. Again, if because of atelectasis, because of stiffening of the alveoli, or because of the fact that you have mucus built up and gas can't get to the alveoli. That's going to be a big problem, because that means carbon dioxide is still sitting inside those lung fields, or sitting inside the blood vessels, and oxygen is sitting in the lungs waiting to try to get in. It's like having a commuter train that's too packed and people can't get on, people can't get off. It's a major problem. Okay. Croup. This is one of the ones we always like to talk about with kids. You'll see it between 6 months, and it says 3 years, but I've actually seen it up to 5 or 6 years. What this is inflammation of the swelling, inflammation or swelling of the pharynx, larynx, and the trach. And this is a significant upper airway obstruction. Okay, everything up to the level of the epiglottis is upper airway. Okay, so what you're going to have with this is you're going to have that seal bark cough. The reason for that is oxygen is having a hard time getting in, and CO2 is getting trapped. Okay, that's kind of a big deal. The thing that, and what happens is the drying out of the mucosa all in there. So the way that we treat this, and you'll want to write this down, the way that we treat croup is humidified oxygen. That's it. You do not give albuterol or anything to a patient with croup. Okay? What you're going to treat them with is humidified oxygen. One of the cool things that we're reading on in your book is that you can actually get flavored oxygen. You take like chapstick or something like that and rub it on the inside of the mask, like the cherry flavored chapstick or whatever, and you can give humidified oxygen to kids. Kids apparently flip over it. It's pretty cool. Okay? So that's croup. Like I said, it's upper airway swelling, everything from the epiglottis up. And what's happening there is you put humidified oxygen on there, or if they're at home, if you have EMD in your area, what they'll tell the family to do is either take them outside if it's a cool night, or have them open up the freezer and stand in front of an open freezer, because they're breathing in that humidified cold air. That's what you want. And that's why we give them oxygen, because oxygen intrinsically, or as a natural property, is that it's cold.
So, all right.
Yeah.
You said if it's a cool night, let them go out or open up the freezer.
Or if it's a humid night out, yeah. Either.
Okay. What if for some reason you used to take hot water in a sink?
You want cool water.
Okay.
Because and you want the cool water, because if it's inflamed, the thing that's going to get it to go down is cold.
Okay.
Okay. Remember,
so it's like putting
inflammation.
ice on.
Just like we do rice with we do the rice acronym when we have something swollen.
Right.
It's the exact same thing. You want to rest, ice it, you know.
Okay.
And you know, you don't want, it's already compressed. Okay. All right. So next we have epiglottitis. Now, nothing scares me or any medic more than this disease, because there really isn't much you can do. The best thing you can do for this kid is to keep them comfortable. Put them on oxygen. That humidified oxygen is what you want. This is a bacterial infection that causes inflammation of the epiglottis. The problem is that if you try to mess with this airway, you have one shot. Okay? These children are in the tripod position. Treat them gently. This is the only child that I would ever let sit in mom's lap during transport or anything like that. They get what they want. Because if they start crying, get agitated, whatever, that airway's going to shut down. Don't put anything in their mouths. You know, if they tolerate the mask, cool. Put them on the mask, drive slow fast to the hospital. Because there's not really anything you can do with epiglottitis, okay? There really is nothing we can do in the field to treat this, other than, you know, if they're on albuterol or something like that, we can assist with that. But other than that, humidified oxygen, high flow, drive real fast. And like I said, this is the only time I've ever let a kid sit in their mom's lap on the way to the hospital, because I did not want the kid crying. I gave them my iPad, let them watch TV, you know, whatever. Anything they want, they get. Okay? Any questions about that?
How can you tell the difference between croup and...
You're going to have stridor. Croup, you're going to hear a Silbart cough. That's your sign and symptom.
Right.
It's going to be a very distinctive, like, epiglottitis is going to be a
Okay.
with every breath. You're going to hear that very high-pitched stridor sound with every breath. Okay? Okay. RSV, otherwise known as respiratory syncytial virus. Okay. The thing with RSV is this is very common in young children. It's an infection of the lungs, lung passages. You're going to have children who are dehydrated. This is one of the telltale signs of RSV, is dehydration. Okay. Airway problems, and we're going to treat them, like I said, with oxygen. We're going to treat them for the bronchitis, the underlying causes, or the underlying signs and symptoms of what they have. Okay, and bronchitis and bronchiolitis is usually one of them. Bronchitis is obviously the larger bronchi of the airway, and then bronchiolitis is the smaller bifurcations, if you will, in the airway. They become filled with mucus, And like I said, the child has a cough, the whole nine. It's a very nasty, like very wet cough. The problem is the airway's so tight they can't move that mucus. So albuterol in this instance is the treatment for that in order to get that airway open. Okay, we have to get that airway open because otherwise those bronchi swell, the bronchioles swell, and gas exchange is not going to take place. So this child has significant problems breathing. Okay. All right. So we're going to give oxygen therapy. We're going to look for signs of respiratory distress. We're going to transport probably emergent because, like I said, if they have albuterol already, then we can treat with it. If not, we're just giving high flow oxygen via blow-by and transporting as such. The thing, like I said, with RSV is a common. It's kind of like COPD in a way with kids. There's multiple problems going on, usually bronchitis and bronchiolitis at the same time. So it's the entirety of the lower airway, or the bundles of the lower airway are all inflamed and they're mucus filled. So with that, like I said, what's going to happen is something called air trapping. You'll hear it referred to as air trapping. That's where oxygen can get in, but carbon dioxide can't get out because of the mucus and because of all the tightening of the airway. So what you're going to hear with these patients is you're going to hear wheezing. That would be your sign or symptom is RSV would be wheezing. Okay? All right. Next we talk about pneumonia. Now, pneumonia is a bacteria. You're going to have, well, you have two different types. You have bacterial pneumonia, and this is somebody that has a fever. It comes on very quick. It comes out of nowhere. And when it affects you, you're going to have difficulty breathing. You're going to have, upper airway swelling. You're going to have, it usually starts as an upper airway, upper respiratory infection is usually how it often starts. Okay? And usually this affects people that have repressed or depressed immune systems. Okay? Some of the things we want to check is we want to check their temperature, but we also want to check their pulse. Because we want to see, is this something that's new onset or is this something that's been going on? Okay? If you have a viral pneumonia, though, that's a little bit different. That's usually what we refer to as that walking pneumonia. And one of the things that you'll have with this is something called an infiltrate. Infiltrates are areas of the lung that are kind of blocked off. It's like almost like clots in the lung. You have a buildup of bacteria and mucus or the virus and mucus inside the lung fields that gas exchange can't take place in. And so you have to treat it with antibiotics if it's bacterial. If it's viral, you kind of just have to treat the side of the symptoms and let it run its course. Excuse me. Okay? But we want to check the pulse and we want to check the temp. Because if they have a high temperature and they have a rapid pulse, they possibly are septic. So we want to treat for the underlying sepsis. How do we treat for that? Keep them cool. From an advanced perspective, we want to give them fluids and treat accordingly, transport accordingly. Okay, but we're going to give them humidified oxygen also. All right. Pertussis. This is whooping cough. Okay. This is also known in the East as the 100 days cough. It affects people under 6 years because these are people that are typically not vaccinated for it. Okay? Whooping cough can kill. Okay? The patient will have a fever. They'll have a whooping sound after the coughing fit. And they'll have a coughing fit that'll last for minutes. It's pretty crazy, actually. You're going to have to suction these patients because they're going to have a buildup of mucus. Okay? This is highly contagious. This is a droplet thing. So that patient is going to need to have on a surgical mask or a non-rebreather, preferably a non-rebreather, so that they're getting oxygen. And you're going to need to have on an N95 mask. Because very similarly to tuberculosis, this is droplet spread. Okay? And even though, and I can tell you personally, even though you've been vaccinated for it, doesn't mean you can't get it. Okay? It is highly contagious, just like TB. Okay? Just like TB. Alright, only thing with this is It's just a tightening of the lower airways, whereas with tuberculosis, you actually have damage to the lung tissue that causes bleeding and things of that nature. Okay? And we'll talk about that here in just a little bit. All right. Then we have flu A. Influenza A is a animal respiratory disease that we started contracting in about 09, 08. The problem with this is it's a mutation. And anytime there's a mutation, that means that it starts out as something we get and it morphs into something that, or starts as something some other host can get, and it morphs into something we can get. That's a problem, because that means that's something that can severely affect a large population. In 09, it formed into the H1N1, which is what we commonly hear about now. But now there's so many different strains, H2N4, H5N6, you know, all these different strains of the flu bacteria, and became what's referred to as a pandemic because of the fact that it affected the entire globe. Okay? Some of the symptoms you'll have with this, you'll have cough, you'll have fever, you'll have fatigue, you'll have a sore throat, you'll have muscle aches, you'll have very significant sore throat. And one of the things you will have is dehydration. Why? Because that mucus that's building up in those lungs, that fluid has to come from somewhere. Okay. It makes you very, very weak. Very weak. All right? Then we have tuberculosis. Okay? And this is a bacterial infection that affects the majority of your lungs. It can remain inactive for years. This is why we do, biannual TB time test to see, if we come in contact with TB, or if we have what's referred to as latent TB, which means we don't have it, but we've come in contact with somebody who does. Okay. The people who have it complain of fever, coughing, fatigue, night sweats. Where you're going to see this the most is prisons, nursing homes, homeless populations, those who use IV drugs and alcohol, and HIV patients. Why? Because they have repressed immune systems. Okay? Your protection, your minimum protection. Remember, TB is droplet. It's a droplet strain that's how it's transmitted. So because of that, we want to make darn sure that we are putting on gloves, we're putting on iPro, and we're putting on an N95. Okay? Alright. Then we have acute pulmonary edema. And what happens in acute pulmonary edema is the fluid that is there running through the bloodstream and into the capillaries during gas exchange actually crosses that semi-permeable membrane into the lungs themselves. Okay? So it starts to you have so much excess fluid that it's starting to back up into the lung fields. Okay? And again, when that happens, gas exchange can't take place. Okay? Gas exchange cannot take place. This is referred to often as pulmonary edema. You'll see this in your CHF patients. The problem is, like I said, the only way to treat this for us is to treat these patients with high flow oxygen and CPAP. Nitroglycerin if they take it, okay? Because what that nitro is going to do is it's going to open up those lung fields, it's going to dilate those blood vessels and cause that fluid to shift back into the bloodstream, okay? Then that only works on the temporary, so they need to go to the hospital and have that evaluated, okay? They're going to have severe dyspnea. They may have pink frothy sputum. That's something you'll see with those, okay? And they have a long-standing history of probably COPD, okay? That means that they have maybe emphysema and another lung problem of some sort, okay? Whether it's bronchitis, pneumonia, asthma, emphysema, whatever. They have another lung problem, okay? The thing is, not all patients that have pulmonary edema necessarily have congestive heart failure. A lot of times it is CHF, but sometimes it can be because of a blood vessel issue, okay, that causes the blood vessels to begin to back up, all right? COPD. and I want to stress this, COPD itself is not a disease. It is a group of diseases